Hello, my name is Dr. Ed Wilson, and I'm a specialist in pediatric ophthalmology and also adult strabismus. I wanted to give you a summary of what the discussion would be like for a patient with adult strabismus who's sent from your office to an office of a specialist like mine. First, we would discuss with the individual the treatment options. These patients have either double vision or a noticeable misalignment that they're concerned about. They could live with the problem, but for some patients it's not that bothersome or that noticeable, and that's always an option. Some patients will come into your office with one eye occluded, and if they wish, they can continue to occlude an eye either with the glasses blacked out or with a patch type occlusion. And often that's temporizing to see if the double vision is going to subside with time and healing. They could consider prisms. That's a service that you likely offer in your office. Prisms are often tried for small deviations that have double vision, and you can try those. That may be a very satisfactory solution for some patients. Botulinum toxin, Botox, can be injected into eye muscles to weaken an eye muscle. That will sometimes bring the eyes back into alignment. As you're aware, this is a temporary solution, and often it has to be repeated. After several injections, you might get enough permanent change in alignment that this is a treatment that lasts for a long time. Or we could fix the problem with surgery. And often if you find that your office discussions and your office treatments are not enough, and prisms and glasses are not enough, then you want the patient to have a discussion of surgery. Surgery is usually possible. Even if the deviation, the misalignment has been there for a long time, surgery is usually possible. I tell patients that it's never really too late to have surgery. This may be something of new onset, or it may be something that was left over from childhood. But surgery is an option that can be done when the patient desires it and wherever, with whatever experienced surgeon they choose for the surgery. I would then discuss with the patient some risks. The risks are small, but they certainly exist. The most serious risk of any eye surgery on the eye muscles is infection. Fortunately, it's very rare. There have been reported cases of patients losing vision or losing an eye from eye muscle surgery. I expect to go through an entire career and not have that happen, and fortunately I haven't had that happen. So I discuss that with the patient, but it's very, very rare. The risks of anesthesia, these are also very rare. Even in the elderly, we don't usually hesitate to suggest surgery. Our anesthesia colleagues are very good at managing health problems. These risks can be discussed in detail with the anesthesiologist, but often the surgery is done with a local or regional anesthesia. At times, general anesthesia is used also. But these are ambulatory surgeries, in and out, and almost never do they really need to have an extended stay in the hospital. I discuss with them that double vision may occur after surgery. Often this is temporary if it occurs at all. We can manage that with prisms or we can reoperate if that's necessary. And again, this is a rare postoperative finding. I would say that 10% or less would have some temporary double vision after the surgery. Long-term double vision occurs less than 1%. Most of those patients had double vision before we started. So again, the percentages are really with the patient that they're going to enjoy a much better appearance and better function after adult strabismus surgery. Our goals are two. We want to achieve fusion and binocularity whenever we can. And amazingly, even those who have not used their binocularity for a long time often get binocularity. One study showed as many as 85% of adult strabismus patients who had been misaligned for a long time did gain at least some measurable binocularity. So we're looking for fusion and we're looking for better appearance. So we are performing a reconstructive goal, allowing them to make better eye contact and have the eyes track better together, but also in hopes that they'll function better from the standpoint of fusion and binocularity. It is possible that we will achieve these goals in certain fields of gaze. I tell patients that sometimes when they look to the side that the misalignment may still be there or the double vision may still be there. The most functional positions are straight ahead and in the reading position. If we can achieve better function and single vision straight ahead in the reading position and then some expanded visual field of single binocular vision, then we're happy. And we can really do that in most patients. It really is a shame for a patient with adult strabismus to live with this condition. They're often told by other physicians that really surgery is not going to work for them and they need to just accept the fact that they have to live with an unsightly misalignment or a double vision that causes them problems with functioning and driving. We tell them that's really not true, and that's part of this video is to educate, help us. We want you to help us educate these patients that a surgical solution is better tolerated and more successful than they might have thought. Recurrence of misalignment does occur from time to time, not as often as you might have thought, but with tissue elasticity and in those cases where fusion is not of a high-grade nature, we do sometimes get recurrences over the years. I tell patients that surgery can be repeated, it can be touched up, the muscles are not damaged by these repeat surgeries, and we follow them, and I often say 90% approximately of patients we operate and get into a straight position will stay that way over the long term. The other 10% will need a reoperation, but that can be done when and if it's necessary. And we look to your guidance and long-term follow-up to help us to get these patients back when they need to be reoperated. For follow-up, often these patients are co-managed with a general optometrist, a general ophthalmologist. It is a long-term relationship often that you have with the patient that helps us. We can intervene with the surgery and rely on you to measure the patients and stay in contact with them and make sure that their functional status, if improved after the surgery, doesn't deteriorate later. Treatments in office, prisms, sensory motor exams, that can be in your office on a yearly or bi-yearly basis, and we are ready and able to help when necessary. In summary, I think the surgical option is often a good one for the patient. We can work together so that many of these adult strabismus patients who are living with an unsightly deviation of the eyes or double vision that they're just tolerating because they don't know that it can be helped. The surgical option is based on dosages we've developed around the country, based on hundreds and hundreds of outcome analyses. The nomograms are good. We know how to realign eyes, and the message really is that these are patients we can help together, and it really would be a shame for them to be told that nothing can be done. Thank you.